So starting with the disclosures, I don't have any disclosures. I'm a Fed. I wish I had financial disclosures. We will also not be talking about drugs. So when NAPCRG called and said, could you come talk about EvidenceNOW? I said, sure, that'll take, I'll spend the whole day. What do you want to hear? And they asked me to focus on what does it mean, what are the issues we're confronting in EvidenceNOW in the field of implementation research. And that was really an exciting opportunity. So what I'd like to do for you today is give you a quick overview, and it's always bad to follow your boss. He already told you what EvidenceNOW is, but I'll give you a little primer on that, but spend most of the time focusing on what the team, and this really was a team at AHRQ, and I'm very grateful and want to acknowledge that I am sharing their work with you, how they thought about this field and the challenges we had as a funding agency in thinking about this field. So to give you all some thinking about how you may in the future want to respond to these kind of calls, or even decide, are you crazy enough to respond when we ask? And if we have time at the end, give you a little bit of update on where we are with the project. You heard about our mission to help create evidence to make the healthcare system better and to make sure that evidence is understood and used. And we do it through those three things, three ways, as Andy told you: generate the evidence, create tools and training to help people understand and use that evidence, and then create metrics and collect data to help healthcare policymakers, as well as those of us working in the healthcare system, understand, are we making progress? So that's our goal. A few years ago, NAPCRG was kind enough to invite me, I think we were still at the Pook Hill Marriott, to give a talk and about the future of PBRNs. And at that time, my prediction for you all, or my challenge to this PBRN community, which as you just heard is really, this is my roots, this is where I come from. And when I started, like probably many of you, our focus was on that first goal: studying, generating new knowledge, using research methods to move the field of primary care evidence forward. And I challenged us all to think about, in addition to studying, are we moving into a place where we are supporting practices, not as research, but as actual practice supports? And that was led by work in Oklahoma and in many PBRNs around the country to diversify. And I got a lot of feedback after that talk that people said, no, we are researchers. But the question came up, well, can you do both? And are they the same? Is it they're studying, they're supporting, and they're studying the support of primary care, which in today's language we say there's research, there's implementation, and there's the field of implementation research. And so that actually was the talk, and we had a robust discussion about it. And that was several years ago, but I'm going to show you today that I took what I was sharing with you very seriously, and we brought this back to the team, and now I'm going to talk about if you give advice, you have to live it. So what happened? We developed EvidenceNOW, and this is the largest grant program in AHRQ's history. Some people argue it's the second. It's one of the largest grant programs in AHRQ's history. And our goal, as listed here, are to actually change the heart health of millions of Americans, to deliver better care through this program. But it's also to study how networks deliver this kind of support services. Can they change not only the outcomes of care, but the system of care, the capacity of primary care practices to understand and to actually use evidence into practice? And our goal is, through doing this, not just to learn that, but to create a blueprint for others in the healthcare system, whether they're in the private sector or in the federal system, to use that evidence to create new programs moving forward. So it's a rather audacious set of goals, but if you unpack that, what we're doing is implementation, with implementation research layered on top of it, and then a sort of combined field of dissemination of implementation and implementation research, which you can pretty much say is that we tried something that people told me we were crazy. So we'll see together if you thought about this. Very quickly, where did it come from? Not the craziness, that's all me. But the why EvidenceNOW in this format really came from three areas. One, as you just heard, our commitment to primary care. When we were given the opportunity to pitch for how to make a large investment, there was a team at AHRQ ready to say, we know it should be in primary care. That is our mission. We believe it is foundational. If you're looking for some more of you have most of these research, but if you get the slides later, I gave you links to them. I'll move through that forward. The second, you also heard a little bit about an incredible opportunity came to AHRQ with the passage of the Affordable Care Act that said AHRQ must disseminate P-core evidence. And at AHRQ, we said, well, what does dissemination mean? That means implementation as well. We weren't going to settle for just letting people be aware of evidence. We went to our mission and said, we have to assure that people are aware of this evidence, but they have the tools and the skills to apply that evidence. So we're going to use some of this funds, and we're going to tie it to improving primary care. And then the third piece of this puzzle fell into place with the announcement of Million Hearts, a federal-wide program to reduce the number of heart attacks and strokes in the US by over 1 million by 2017. And the department turned to AHRQ and said, what are you going to do to help the nation meet this goal? And our answer was, well, we work with primary care practice. We work with the healthcare delivery system. So while our colleagues in CDC were doing work on public health, where our colleagues at FDA were going to change salt labeling, which, by the way, just happened, we were going to see if we could help primary care practices change how they delivered the ABCS of primary care. So we put those three together and called it EvidenceNOW, Advancing Heart Health in Primary Care. So you see those three streams. Primary care at the end there, advancing heart health is the alignment with Million Nows, but the big thing is how do people use evidence? As I said, the largest initiative in AHRQ's history, over $100 million investment over a 4-year period, creating 7 regional collaboratives through a competitive grant process and 1 national evaluator also through a competitive grant. It is now, our goal was that we would work with over 1,500 primary care practices around the country. We estimate that's 5,000 primary care clinicians and 8 million patients. Truly one of the largest primary care studies, we believe, done in the US or potentially in the world. And so now I'm going to sort of start shifting a bit here to get more into the details. So what are they doing? Each cooperative has to work with over 250 primary care practices. And again, their focus is on disseminating and implementing evidence, or as for this project, patient-centered outcomes research findings. And we targeted them to the ABCS's, aspirin, blood pressure, cholesterol, and smoking cessation support to improve heart health. And while they're doing that, they're needing to look at the capacity of the practice to understand and use evidence moving forward. So here, and you might have seen it on a slide earlier, are the 7 cooperatives in 12 states, a nice geographic spread. We were thrilled when we put this out that despite the craziness that you're going to see, that a lot of people took us up on the offer. And one of my takeaways is, I think I know why that happened, but there were many, many great applications. These rose to the top. There's also the National Evaluator that is based in Oregon and a Technical Assistance Center based on the East Coast. We'll talk about that. We asked these grantees or these applicants to think about 5 what we considered evidence-based strategies for implementation and to study these. And those, if you start at the top, are data and benchmark and feedbacking, giving people information about how they're doing and how their peers are doing, supporting electronic health records and health IT and information. How do you use the systems you have? How do you get better systems? How to use EHRs not just to deliver care, but to improve quality? The 2 on the bottom, local learning and learning from experts. And then finally, what we really saw as the secret sauce in this was practice facilitation or practice coaching. And this was based on the idea that AHRQ had, that you all are the pioneers in, but we learned from you that primary care practices often don't have the internal resources to think about quality improvement and the skills that come with that they are delivering care and trying to meet a bottom line, and that this is extra and there's not a lot of room for extra, and that providing this support externally could be a model for supporting them that they would receive well, that would lead to changes in quality. And so that's what we're testing. Can practice facilitating bring these other 4 services and change both outcomes and capacity? Our timeline, we announced this in 2014. We launched it in 2015 with the awardings of grants just over a year ago. The cooperative spent the first 3 months just getting established, popping champagne corks, hiring new staff, and about 6 more months recruiting those 250 practices. They're now all in the field in different at different points in their implementation, intervening with real primary care practices. They'll do that for another 1.5 to 2 years. And then there's an evaluation period which goes beyond the actual implementation. So there's some follow-up, and then even longer follow-up to put together the national answer. At least that's our hope. So let's switch over now. What were we thinking? As I said, they told me I was crazy. What I told them is that I thought this was impossible, but we were going to try anyway, and that's a recurring theme here. So we'll think about this in 2 sides. I told you there's implementation and there's implementation research. So what were some of the questions we thought about in implementing this kind of work? First, we said that we required that people came in as collectives. We called them cooperatives, and that was based on the idea that these kind of externally provided supports probably don't live in any one organization. And that to be sustainable in a community, rather than having multiple people knocking on primary care doors, we believed it was important to get all of those people who had a piece of this puzzle together and target them working together so there was one entry point for primary care for this external support. We believed that if multiple people tried to do this, even if they could do it well, they would cancel each other out, and the practices themselves and their patients wouldn't benefit. So we told people you have to come in as a group. Next, we asked that this work focus on what we thought there were a lot of, and we'll talk about that in a minute, but small independent primary care practices. And that was based on the idea that there are practices, primary care practices in the United States, who are already receiving external support. And we know that from our colleagues at the VA, and we've seen it for some of the larger integrated networks in the country who figured out how to do this, how to provide support from outside of the practice to the practice. And since they were already getting it, we asked that these grants focus on those practices less likely to currently be receiving the kinds of support services we talked about. And even though this was a research project, and actually because it was a research project, we asked that they not go out and find the best in breed already, the people who are already delivering high quality health care focused on heart health and using the evidence, that we find the garden variety practice in the United States and see how we can help them. So that was a choice we made. We got a lot of pushback when we said that we needed these grantees to be regionally cohesive, a defined geographic region, so that we could show it on a map. Not so that we could show it on the map, but because as a federal funder, our view was a little longer term. That if this works, and if we can create an infrastructure here that could be built upon, it's hard if one group is working on supporting community health centers, and another one is working on helping family physicians, and a third one is working on internal medicine physicians. What about the community health center that has family docs and internal medicine? You don't build a network that way. So being the small-minded government bureaucrats we said, let's just divide the country up, and that way we can make sure eventually every region is covered. Some people agreed, some different. You can tell us whether we got it right, but that's one of the reasons why we started with this regional. It was also because we believed that healthcare is still local, and that local knowledge is important to moving this forward, something we can test in moving forward. Many of you told us during our fact-finding that the practices most in need of the support often didn't have electronic health records. And so we made a very difficult decision when we asked the grantees to say that they weren't going to focus on those practices, that they could include some, but the majority of this work had to focus on practices who already had EHRs. And our reasoning behind that was that the future, when it comes, will be one where there are EHRs. So asking the implementation research question of how best to support practices who don't currently have EHRs would limit the value of the final answer. And so this is one of the many tensions we had about helping people now who need that help, and the research question to generate knowledge that would be useful in the future. There were those at AHRQ who said only EHR practices. There were those at AHRQ who said, no, we should be focusing on those with the highest needs. And so we sort of split the difference a little towards the future by asking them to target at least 60% of the practices having EHRs. Interestingly, the grantees that were eventually selected are showing us rates at 90% at least have EHRs, if not higher. So switching over, those were some of the designs for the cooperatives, but now let's get into some of the questions about the tensions in the design for implementation research. So the first is that despite the fact that, and because of the fact this was both implementation and implementation research, we required each of the implementation grantees, the 7 cooperatives, to have robust internal evaluation plans. We required them to look at process outcomes. We required them to look at capacity of primary care practices. So those 2 implementation goals are the first 2 evaluation goals, but we made them go further. We asked them to think about implementation as something that changes over time and to study that, to collect information about how their plans changed when they hit the ground and how as time moved forward they continued to change. That's the last thing. They needed to have an evaluation that looked at the process of implementation and adaptation. And then we also were very aware that this is about context, both the internal context of primary care practices and the external context that they're operating in. And they have to study those factors so that we will understand here not just does external support change the capacity of primary care, but what type of practices, in what kind of setting, experiencing, and have a better blueprint of how do you actually do this based on what we learn about change. We also required, because this was a research study, that they have a validated form of control. Some of them chose to answer that challenge by having an external control group. Many of them chose to do this using their methodologies to have internal control groups using things like a step wedge design. When we originally proposed this project internally, we said, this is about spreading evidence and getting evidence into use, so why don't we let the cooperatives tell us what is the most important evidence right now in their communities? And that's how this project actually got launched. Until somebody said back, but our second goal is to create a national model about how to do this. And if everybody's doing something slightly different, or in fact, maybe radically different, not just in how they're doing it, but what their goals are, how can you compare them? And so we wrestled with this one for a long time, and in the end chose to have everybody have a shared focus. We allowed them to choose their implementation strategy individually, and they are quite diverse, and that we think is a strength for the overall project. But by having a shared set of common evidence that they're working on, and then a shared set of measurements that are derived from that, we're hoping that the national evaluation will allow us to tell a larger story than what 7 implementation projects, separate implementation projects, would do. As I said, what the decision above let us do is create this shared set of harmonized data elements, and I think the next 2 slides show you what they are. For those first 2 goals, the process measures, we picked across that, so all 7 cooperatives are now using the same measures for the ABCS of heart health. Are these perfect? No. Are many of them using other metrics as well? Yes. But they all are doing this as a minimum shared data set. And for practice capacity, they're looking at 2 validated measures, the adaptive reserve and the change practice capacity questionnaire across the 1,500 practices. So as we try to answer that question, how does this work for different practices in different contexts, we'll be able to look at shared metrics of change and outcomes. One of the biggest decisions we made was to not limit this to the internal evaluation, but to recognize that there was something greater taking place. We often in the federal government, and you know this from our colleagues at CMS, commission through a contract mechanism an evaluation based on our needs. And for this program, we made what for AHRQ was a new step, and we said, no, this can also be a grant, that we wanted the best thinkers out there to propose how they would come up with evaluating across these 7 grantees. So an independent, overarching, external evaluation created through a grant mechanism. Here were the things we asked for them to do: to give us a summative evaluation across the cooperatives, to identify the different factors that led to successful or not successful implementation, and the strategies within those that, and whatever they could tell us about that. The other thing that this let us do, and I missed it on the word, so I'll point it out, is by not contracting to do this, by doing a grant, the grants, as you all know, are independent of their funder. And so we are hoping that people will have more faith in the findings of this evaluation, because it's not the federal government saying, or AHRQ specifically saying, we just did the largest investment of our kind, and look, it's a good answer. We hope when they find good results, people will have faith that those are true good results, and that they'll feel more comfortable coming back to us with some of the not so good results that we might not want to hear, because they are an external funded grant. They are completely independent of the federal government. So that's their metrics. In doing this, given that our focus on implementation research, we required that folks not think about this project as we're going to go away and do our work, and then we are going to spend some time analyzing our data, and then we are going to go through a peer-reviewed process to make sure it is high-quality analysis, and then we will release the results. We're actually requiring them, both the implementation grantees and the national evaluator, to collect data on an ongoing basis and to make those data and their preliminary findings publicly available. Okay, and I said that. So every 3 months for the ABCS, starting at a baseline and then continuing 6 months after active intervention, and practice capacity at baseline at the end of active intervention and 6 months later. And some of you, I know, are already starting to think, 6 months, that's not enough. Let's talk about that too. So as I said, as we put this out, people said, no, really, you're crazy. But we went further. We had some other design choices I'll just point out to you. Actually, I did this one already, that we required them to show us how they would disseminate both back to primary care, but also to policymakers, starting early and continuing, both the individual grantees and the national evaluators. Here was one of the ways we made this lesson possible. We recognize that implementation is hard, research is hard. If we ask you to do both simultaneously, we need to fund you to do both simultaneously. And we had made some difficult choices about size and scope and reach and timing and available funds, trying to come up with a fair grant size. And we think, based on the response we got in the number of people who are willing to take us up on this crazy challenge, that we hit that about right. The PIs and the POs are continuing every day to talk about, should it have been more? What else can they do in flexibility? But overall, we think that this was part of the decision that made this and is making this work well. And so we will share that with others so that other funders recognize that to do implementation and implementation research simultaneously, you can't fund the implementation and expect to get the research for free. You all taught us this. This is about communal learning. So we also invested in a national learning system. That's what CMS would call it now, but an active learning community. The 7 grantees are sharing with each other the materials, the problems, the solutions they're having. The evaluator is watching that develop as well and telling another story through doing that. But the overall goal of our Technical Assistance Center is to help them go further together than any of them would have gone by themselves. As we talked about, there have been tensions along a few others. The timing of this grant, how long? Some folks there is an enormous pressure on federal agencies to produce results immediately. If you invest this year, show us the results. Now, clearly that's impossible, but it is an important tension. So what we chose to do here, listening to the community who said, primary care change, practice change, the results don't show up after a year, maybe 3 years, probably 5 years of continued work. North Carolina folks talk about 10 to 15-year horizons on investment. 10 to 15-year horizon investments is like speaking in dog whistles in Washington, D.C. Not possible. So we chose we compromised, and we asked them to do this work in 3 years, recognizing some of that 3 years was the organization. So really 2 to 2.5 years of data collection with that 6-month post follow-up. We gave the evaluator, the national evaluator, a little extra time, recognizing that despite the fact we wanted everybody to be done at the end of 3 years, some of them might take a little longer to do their analysis, so the data might be coming in a little later, so we gave the national evaluator more time. This meeting, for me, has had many folks talking about this question of how do we balance internal versus external validity as implementers, as researchers, and as implementation researchers. The way we chose to do this is by having a little bit of both. The shared metrics that are really a process outcome measured over time and post-intervention gives us some sense of the internal validity of this work. But recognizing that things are going to change and that we need to let them change as the grantees learn starts creating more external validity, threatening our internal validity, and we balance that by asking them to collect those 3 things: internal context, external context, and most importantly, adaptation and change over time. And I'm rushing to keep us on time here, and as I talked about, sharing results was an important tension here. The researchers at AHRQ and our federal partners who worked with us on this initiative talked about the need to protect this data and that to only release analyses after they had been vetted. And that's a common understanding in potentially an older way of thinking about research. And we pushed the envelope here a bit by saying, while we understood that tension, we looked for researchers, and we wrote this into the FOA, who were willing to say that they would find creative ways to share preliminary findings, to share lessons learned as they were learning them, recognizing that they may have to go back and change them. But in doing so, to build a community who would be interested in the results of their work as they moved forward. So, trying to do 6 impossible things before breakfast. I think it should be AHRQ's slogan. Okay, so how are we going? Recruitment started slow, as expected, and has progressed wonderfully. We broke 1,500 in the early spring. Some of the grantees' designs will allow them to continue to recruit for another few months. So congratulations to them. We are feeling really good about that. I'll tell you a story, though. This was a lot harder than we thought it was going to be. And this is why. The landscape that we were imagining, now we knew healthcare was changing. That's why we were doing this. Right? We know there are major payment changes taking place. There are major changes in the organization of medicine and in our evidence base within medicine. But the consolidation that's taking place in healthcare right now, the small independent primary care practice who we thought was most in need of this service, these changes are making them disappear. Grantees who showed us how many primary care practices were in their region and were shooting to capture 25% of them came back and were telling us half of them are gone. We have much higher recruitment goals, if you look at it in a percentage term, than we thought. There are also many other initiatives competing for people's attention. That's great that primary care is in the spotlight. For an implementation research program, that's tough news. We're going to roll with it. The other challenge, and I wish we had a lot more time for this one, and I saw it in the folks who came to the EHR session here at the PBRN meeting. We expected that there would be challenges using EHR data for research. What we've been shocked to discover is how poor EHRs are in supporting the practices themselves in understanding how they're doing. So for quality improvement, and there are many people nodding. Some of our grantees said this. Yeah, Mort's like, yeah. We knew it's far worse than we thought, and this is a real challenge for the entire initiative. If they spend too much time cracking the EHR code, all the rest of the things they were hoping to do may not be able to get done in time. That may be a very important story. It may be worth the value of this entire investment just to tell that story about primary care. We're hoping we can tell that story plus a bit more about how to support primary care practices. Okay. As I said, our goal is to share this along, as we go along, so I encourage you, if you're interested, to continue following the story with us. The website, arc.gov, EvidenceNOW, will teach you anything about the metrics and how we're doing and who they are and what they're doing. But I'd love to have you all have a discussion with us now about, does this resonate? Are these the tensions you're feeling as you think about PBRN research in both implementation and implementation research? And while this train has definitely moved, we hope there are others in the station getting ready to launch or start. So your thoughts on, did we get it right? Where did we get it wrong? Or where can we do it better next time? We'd love to hear.
David, I think an area which really is problematic is, at least in our area of the country, virtually every small practice has been phagocytized by some much larger healthcare organization. I think I could say in Wisconsin probably 80+% of care is delivered by perhaps 10 or a dozen large vertically integrated organizations. So if we had this to do over, it might be the question of how do we get large vertically integrated organizations to shift in situations where the individual clinician or clinic have really very little control.
Great point. One of the things, as we said, we're changing as we go. We're learning for them to do their recruitment. Many of the cooperatives needed to find these systems, and we had originally said, you can't work with a system, but we were at least forward-thinking enough who is providing significant quality improvement support to their small practices. And the very smart people in the field came back to us and said, yes, they're not. Their experience is there are many large systems who have created economic alliances but are not yet providing quality improvement support to the practice. How about we work with them? And we said, yes, go do it. And the first lesson back we've gotten from them is that worked for recruitment. The large systems in general were very receptive to this idea. They weren't in denial, and they said, wait, you're going to give us free support? Great, come on in. So, something I think at this PBRN meeting 10 years ago, we wouldn't have thought was going to be their response. But a new problem has emerged, and that is these practices who have been bought into large systems, when the boss says, opens the door, they don't open their doors. And so you now have this two layers, and we thought the hard layer was going to be easy to get the practice in and hard to get their boss to agree to it, and it turns out in many places it seems to be the reverse. It's easier to get the corporate people to allow you in, at least in this non-threatening program, but then the practices say, wait, I'm doing this, I'm doing this, I'm doing this, I'm doing this for my corporate boss, you're not really here to help me. We're learning together how best to do that.
David, Paul over here. What's CMS's perspective on this EvidenceNOW? Because I think that one of the real things is to kind of influence them.
You're right. So thank you. Great setup. When AHRQ created this program, we were finally at the big table. So we're excited. We finally had enough zeros that somebody saw us. So CMS has been very, very, and to their credit, especially CMMI, are incredibly collaborative and innovative folks. So they have followed very closely with us this program. We were able to put together a document that explained the different CMMI initiatives that might affect primary care practices and EvidenceNOW and line them up. And CMMI went through with us and gave approval on every single one of their initiatives, that you could participate in both, that there was not an exclusion. Even at times where CMS was saying, you can't do two of ours, but that they opened us up for this. And part of the reason I think they wanted to do that is they see this as informing their future work. Best of all possible worlds, we would have gotten this off the ground and further along before some of their large programs moved forward. We don't live in Voltaire's world yet, so we're feeding them these results as fast as we can get them. Some of the work that AHRQ did here, but actually some of the background work that led to this, helped create CPC and helped them in their thinking for CPC+. So we hope that that kind of collaborative will continue to work on that implementation and implementation policy side. And interestingly, our NIH colleagues are very excited about this work and are following with us and are interested in understanding what this data means, how they might continue this kind of work with us moving forward. So we're working with both the research side, the policy, implementation, healthcare delivery system reform side of the House, we actually put together a steering committee or a advisory committee of other federal agencies who's been, I'm very happy to say, very engaged with us in a positive way. So thanks for the question, Paul.
David, Artis Olson, I just have to reinforce so much the message that practitioners have bought a shell of an EHR or have been provided it by their newest hospital network that's brought them up with expecting they were going to get report and analytic capacities. And with the exception of maybe one or two nicely ambulatory EHRs, docs don't have it, and then they're caught in the queue with limited QI resources. You think it's bad here, wait till you try to take a pediatric issue. Then it's practically non-existent to be able to get those resources. So I think that's the elephant in the room, that we've constructed a commercial model that they were all prepared to charge more to give those next level of services when it was needed. Anyone comment?
I can't add anything to that, Artis, thank you. I can say that the cooperatives, in our push with them to say, what are you learning? What story can you tell? How can you tell that now, not wait till the end of the grant? This is the #1 story they want to tell. And so I expect in the next 3 months, several publications and stories coming out trying to make that point to policymakers, to healthcare decision makers, and to give primary care some warning, but also evidence about what they're experiencing. And I will also take home what I heard as your second point. This project focused on a large part of the healthcare system, a large part of the primary care health system, and is missing pediatrics. And so we are aware that those questions of, well, are they the same for supporting pediatrics? Do you need, it's worse, so what resources are necessary external support for pediatrics is a great question. And you don't have to wait for us to answer that, by the way. You can come in with a grant under the SEN to answer that.
You know, the other sort of dirty secret, I think, about EHRs, and I'm just wondering, I'm sure it's coming out, I'm just wondering how you all might address it in future, perhaps SENs, not sure. But in addition to having a massive adoption of EHRs, lots of practices, regardless of what EHRs can do or can't do, use it like people who have Excel and use it as graph paper, right? It's a they use it in a very two-dimensional way, and they often maintain competing paper processes on the side because they need that to function, and they often live in a world that doesn't allow for an electronic exchange of information, so they may send things out electronically but get them back in paper, and if we scan them in, they're not mineable information point. You know, there's this sort of, I really don't buy how many people have EHRs as a sign that people are using EHRs. I've gone to lots of practices where I do site visits, and we enrolled them because they had EHRs, and everything they're doing for our project is on paper. So I'm wondering how that plays out, and if it might have implications for future sort of implementation research where the topic actually has to be, how do we use EHRs?
Great question. So you heard in the AHRQ infrastructure, there's the Center for Evidence and Practice Improvement that Arlene Bierman now runs. It has its 4 divisions, one of which is health IT. That's their question. The reason, and if anybody ever asks you, and especially if somebody in DC ever asks you, well, why should AHRQ have health IT if ONC is here? AHRQ's question is not how to get magic boxes in everybody's office, or not how to get the magic boxes to talk to each other, but how are systems using health IT to improve quality, to improve safety? Those are the questions that are of interest to AHRQ. So I guarantee we will continue to ask that very question. And these grantees are absolutely trying to they're going to tell their first story about what the current state of EHR is and what primary care practices can and can't do. But the story they're much more interested in, and I think this project is how to teach them to use their EHRs not as spreadsheets as in that world, but to truly change how they deliver care and think about how to deliver care and change over time. That is one of the major goals of all 7 cooperatives.